Okay, so last class we talked about the shoulder joint. Today we're going to move down the arm to the elbow, forearm, wrist, and hand. We're not going to focus more on the elbow than we are the wrist and the hand, but they have some muscles that go across all of them, so it's important to talk about all together. So just going over quick the anatomy of the elbow. Here we have three bones that are involved. We have our humerus, which is also obviously involved in our shoulder, and we have our ulna and radius. So our ulna has the main is the main elbow joint. The radius just kind of has an articulation with the humerus and glides along, but it doesn't really support the elbow at all. It allows for other motions like supination, pronation, which we'll talk about in a minute. But the ulna has that olecranon process, which you can see here at the back of the elbow. That's your knobby part of your elbow. That fits really nicely into the back of the humerus, and it provides a very stable joint. I know there is some people in the class that, I think there was two people that mentioned that they had seen elbow dislocations. It's actually a lot of people to have seen that, because that is a pretty rare dislocation to see. Generally the shoulder will go out first because it's not as stable as the elbow, but it does happen, and you do occasionally see it. And we'll talk about that more when we talk about injuries a little bit. So this slide just goes and shows you those articulating surfaces, and you can see just how much more surface area that olecranon and the ulna cover on the humerus as opposed to the radial head. Ligaments. On the medial side of the elbow, the humerus attaches to the ulna via the ulnar collateral ligaments. There's three, and this picture does a pretty good job of showing you the different directions of the ligament fibers. Purposefully, the different directions allow for better stability in multiple directions. So you see the one, the one that's connected to the medial epicondyle and kind of going straight across here, the anterior cord. That one's going to prevent the ulna from moving away from the humerus in that direction, where the oblique is going to kind of go more, avoid the sideways motion, allow that stability. So just having those three different directions of fibers is going to just increase the stability of that joint even more. We have our annular ligament, which wraps around that radial head, which allows for it to move, but also then holds it to the ulna so that it won't pop away from it. You also, on the lateral side of the elbow, you have a radial collateral ligament, which isn't as impressive as the ulnar collateral ligament on the medial side. And you do have one lateral ulnar collateral ligament, but it's very thin and not as supported as these ones that you see here. Moving on to muscles then, obviously we have the main one that people think of when they think of the elbow are the biceps brachii muscle. Because of the position of the biceps brachii muscle, it attaches right at the radial tuberosity. Because of the position of this, when the radius is folded over the ulna in the pronated position, the biceps is a very, very strong supinator. The biceps is a very strong supinator. So when your palm is face down, the bicep helps to pull your palm up. It actually does that a lot better than it does elbow flexion. Elbow flexion, the brachialis and the brachioradialis contribute a lot, especially the brachialis contribute quite a lot of force for elbow flexion. And so the biceps, yes, does assist in that, but it's definitely one of the more powerful supinators that are found in the elbow. We also have the triceps tendon, obviously on the back, that attaches to that olecranon process, and a strong muscle that then splits into 3 heads as it gets to the shoulder. Moving down the arm, these muscles all cross more than one joint. They cross the elbow joint, and then they cross the joints at the wrist, and some of them even extend out to the fingers. Sorry, I shouldn't say that. Not all of them cross the to the carpal bones, but the elbow is predictable in that on the lateral side of the humerus, so right here on the lateral epicondyle, is where all of these the wrist extensor muscles and finger extensor muscles come off of. And then on the medial side, so the medial epicondyle, is where we see in the next slide our flexors come off of. So there's 4 main muscles here. The palmaris longus is an interesting muscle that 25% of the population doesn't even have. So if you were to pinch your middle finger to your thumb, you should see in your wrist a tendon pop up. If it does not pop up, then it's very likely that you do not have a palmaris longus. If it does pop up, then you probably do. But so those are attached to that medial epicondyle on the elbow. And so these muscles, just like any muscle, they can produce an awful lot of force, and which can cause problems then on those epicondyles. So this picture just goes on into looking at the superficial muscles, which we just talked about, and then also some of the deeper muscles. And we see we have lots of these muscles that attach to the forearm bones, but then shoot down into the fingers to help control the digits. We have our supinator, which assists the biceps in supinating the arm. So supination and pronation, as I've mentioned a couple times already, these are very unique to hand and foot motions, or I should say forearm and hand and foot motions. So when we're talking about the elbow, it pretty much only has 2 motion. It has 2 planes of motion. It has that flexion extension, and then that pronation and supination, which you can see in the picture here, and that's just going from palm down to palm up. Anatomical position then is in a supinated position. When we look at the bones of the hand, obviously it's very impressive, all the different carpal bones, and then small bones that we have going into the fingers, which allows for a lot of dexterity and a lot of motion within that, because each of those little joints can move on one another. We see in these pictures too that there are lots and lots and lots of joints throughout the hand. Every place where these bones connect obviously is a joint. And these are very, like their name says, they're called cuboid bones. They're not cuboid bones. The cuboid is one in your foot. But all these bones are cube-shaped bones that are basically just like boxes stacked on each other. And so it's very easy to slide boxes across each other when there's no bony stability, like where we see in these bones. So that requires, in order to have stability, to have a lot of ligaments, especially since there's not a lot of muscular control in this area. And so we can see on the next slide, we see our all the many ligaments that connect all of our carpal bones to our metacarpals and to our ulna and radius. And so without these, those muscles would just slide along each other. And it's not uncommon to have a carpal bone dislocate. The capitate right in the middle, the big one, is the one that commonly will dislocate in athletes. Along with, in this area of the carpal bones, we have our carpal tunnel. And so all this is where we have a ligament called the transverse carpal ligament that spans across these carpal bones to help hold down a lot of these tendons that then help to flex our hand and our fingers. If this tendon wasn't there, if this ligament wasn't there, the tendons that run underneath it would pop up and we wouldn't be as able to perform flexion. And we'd have like weird skin patterns and such to accommodate for that. So that ligament is very necessary to help hold all those structures down and to keep them in a contained area. The hand, like I said, doesn't have a lot of muscular support within it. It has, some lumbricals and some interossei muscles that are within the fingers, but those, all they do is AB and adduct the fingers for the most part, and they're not very supportive of the joints. And then obviously we have the little finger and especially the thumb have some more musculature to help perform with some gripping and things, pinching that we wouldn't be able to do otherwise. Interestingly, this adductor digiti minimi brevis, which is this little muscle right here that adducts your pinky and sticks out to the side, that muscle has actually been studied very highly in motor learning and biomechanical studies because of its ability to pretty much just produce one motion, that abduction of the pinky, and because of its location so close to the surface, it's very easily controlled muscle and easy to train as well, so they can do some muscle training research on it and kind of see how it reacts. Not to say, though, there have been problems with some research studies showing something occurring in that muscle, but then when they try it on other bigger muscles, it doesn't necessarily happen. All right, for our wrist and hand motions then, at the wrist, we have our flexion and our extension, and then we also have AB and adduction, which is more often called radial or ulnar flexion or radial ulnar deviation. And this especially helps when your hand's not in anatomical position, which it generally isn't. It helps to better get an idea of whether or not that hand is moving radially to the radial side or the thumb side or to the ulnar side. Fingers then also have flexion extension and AB adduction. And then there's also opposition, which we see of the pinky and the thumb only, and that's pretty much when you bring your pinky and thumb together and touch them with the other three fingers positioned straight up, as you see in the picture over here. So a couple of common injuries that we're just going to go through quickly. I already talked about the importance of the carpal tunnel and holding those tendons down, but a lot of people that do a lot of intricate work with their hands often will have carpal tunnel syndrome, which I'm sure most of you have heard of. And so along with those tendons that run under that transverse carpal ligament, we have one of our main nerves. We have an ulnar nerve and a median nerve that come down into our hand. And the median nerve controls as you see in this picture, generally the thumb and then the first two fingers, sometimes part of the third, sometimes only half of the second. It's different on each person. And then the ulnar nerve is the one that will control the outer two fingers. And so what happens is because this nerve runs under this carpal tunnel and with these tendons, sometimes you'll get inflammation in this area. So the tendon, you could have tendonitis that causes some inflammation. You can just have the tendon sheaths that are irritated and start inflaming. And any kind of inflammation that occurs in this now tight spot from this ligament, the transverse carpal ligament, is going to put pressure on that nerve. And so this can cause sensation down the median nerve into the thumb and those first two fingers. I should say the two fingers closest to the thumb. That can either, sometimes it's just tingling and numbness, but sometimes it can be very painful. The coronoid process, so here we have our brachialis muscle that connects to the coronoid process of the ulna. Sometimes because of the force of that muscle, it can pull off a part of the bone, what's called an avulsion fracture. This can happen with any muscle and any bone. I actually saw one on someone who had a bicep tendon rupture and pulled off a little piece of the bone. I was able to see them repair it, and they just pretty much put it right back in the same spot and put some sutures through the bone, and it kind of heals around the tendon, and you're able to function again. But yeah, avulsion fractures are very common because of all the stress that muscle puts on that area of bone. Sometimes you start to get micro tears, which then lead to a full-on fracture. Epicondylitis is basically, so we have our epicondyles of our humerus, which are the little nubbies on the medial and lateral side. So epicondylitis is essentially inflammation of those epicondyles. We have what's called tennis elbow here. There's also golfer's elbow, which tends to be on the other side. Tennis elbow is generally on the lateral side, where all of your extensor muscles are attached, and then golfer's elbow tends to be on the flexor side, or the medial side, I should say, with all the flexors attached. And a lot of times this occurs in, they call it tennis and golfer's elbows because you see it so often in those types of athletes. But it's a result of the muscles eccentrically contracting, and also the ligaments on the medial and lateral side of the elbow being stressed during the backhand in tennis and while someone's driving in golf. So that puts extra stress there, and it starts to get inflamed, and then it's a very annoying injury that is hard to get rid of. Basically, like any other muscle strain, they just take time and rest, and that's something that athletes don't necessarily like to do.